Good afternoon, everyone. Welcome again to Eckstein Hall, Marquette University Law School. I'm Mike Goucher, and this is On the Issues. This is our continuing series of conversations with news and policy makers, people who are doing interesting, important work in this region and beyond. Today, we're going to be talking about the opioids epidemic in the state of Wisconsin. It's an epidemic that is not just a Wisconsin phenomenon. It's happening all around the country. But there are steps being taken to address it, and we're going to be talking about that today with the co-chairs of Governor Walker's task force on opioid abuse. Joining us today are Lieutenant Governor Rebecca Kleefisch and State Representative John Nygren. Won't you please give them a warm welcome to Marquette Law School.
It's afternoon now.
Did I say morning?
No, I said good morning. 19 after.
And my apologies for starting late, too. It's really my fault. So we're always very big on starting on time here at 12:15. In fact, we were just talking about proceedings starting on time, and I just violated my own principles there. So my apologies. I wanted to begin by getting a sense of the scope of the problem. And Lieutenant Governor, I'll begin with you. The Attorney General, Brad Schimmel, said back a couple of weeks ago, I think, that this is a public health crisis and public safety crisis, the likes of which we have not seen in this state for decades. Do you agree with that assessment? Is that how you would describe what we're facing right now with the opioids problem?
I think Brad is very eloquent in how he puts it. I would describe it as an American epidemic. It does not have any geographic limits, has no demographic limits, and this is a crisis that has crept in some cases silently into homes all across America, touched by something that once probably was unthinkable. But now that everyone in every community has potential for exposure to this crisis, let's start talking about it. So thank you for having us today. Yeah. Thank you for providing a forum to discuss this.
Glad to have you here. In terms of numbers, Representative, how many overdose deaths are we seeing in Wisconsin these days?
Well, I mean, just to try and put it into context, I mean, we're seeing more overdose deaths than people dying of car crashes.
So more than 600 in the
More
state.
than 600.
And that was in 2014, right. 644.
Right. So, I mean, it is as mainstream as any other type of disease that is, you know, it's bigger epidemic really than AIDS was in its time. So it's getting people's attention. I think that's rightfully so. Based on the enormity of it.
And when we talk about opioids, let's spend a moment or two on what specifically we're talking about. And each of you can weigh in on this. Representative, begin with you.
Well, my world of opioids, actually, it didn't really start with opioids. I didn't even know what opioids were. A prescription drug, I get that now. But my world really started with heroin. At least that was my understanding of the problem at that point in time, through my daughter, Cassie. Cassie was born on Valentine's Day in 1989, just celebrated her 28th birthday recently. Thankful for another birthday. When she was, this was a girl who was very smart, very bright, basically a straight A student until we learned there were other issues. But she had some struggles in her life, such as her mom and I divorced when she was younger. She also had a teen pregnancy, about 16, that she decided to give the baby up for adoption. And some things we didn't really know about until the addiction kind of reared its head. But Cassie began having truancy problems at school, grades started slipping, so the girl that should have been heading off to college actually just did not graduate from high school. But that wasn't really the scary thing in all of this. The scary thing happened much later when we learned that she was addicted to heroin. The day that her mom called me, I still remember it very vividly, called me. She had gone home on an August afternoon and shut the windows because there was an approaching thunderstorm, and she found Cassie passed out, purple, needle still in her arm, and called me. I raced over. I got there before the paramedics did and tried to help her breathe and did a little praying during that time too. Paramedics came. Marinette, I'm from northeast Wisconsin, Marinette, and we have both paramedics and basic level EMTs. The paramedics showed up first, thankfully, because at that point in time, under state law, paramedics could carry and administer a drug called naloxone, and they administered that drug, and she came back to life. That, because she was in possession, that event, because she was in possession of drugs, began what was a 3-year period of incarceration. that took place over about 5 years, and I can get into those details later. But that was really my awakening to this issue, that Marinette, Wisconsin, population 10,000, the community I grew up in, had heroin in it. And this was a community, like I said, I grew up in. We didn't lock our doors. The mom down the street was just as likely to raise you as your own, and yet heroin was in our world. We learned later the background behind the heroin was really prescription drugs, in Cassie's case and in many others, but that was the entry point for us.
And this is, and the representative, and thank you for sharing your story, we appreciate that. But this is, it's a lot of this is about legal medication too. It's about prescription painkillers and their incredible popularity in our society today.
I think, first of all, I'd like to compliment the representative for his willingness to share his story. This isn't easy, guys. There is still a lot of addiction stigma out there, which makes a day like today, where we talk about this publicly, and we hope that you will go home and talk about this with your friends and your neighbors and your family tonight over dinner. For the representative to be willing to share his story across the state and with other leaders nationally, I think is really special, because it is humbling to expose your family to whatever criticism may come, because we all know when you develop public policy, there will be criticism. And also Cassie's willingness to share her story. For a young woman...
Honestly, that's the most important part. Cassie stepped forward saying, "We need to do this, Dad." So.
For a young woman to have that type of confidence, I think is awfully bold, but also awfully benevolent to those who also may be struggling with addiction. We can talk about the peer-to-peer support in a minute, but you mentioned prescriptions. So John's first experience was not with prescriptions, right? He said it was heroin. Right. That's not necessarily the way it happens for every family in Wisconsin or countrywide. In fact, we know that about 80% of these addictions actually start with a prescription. So that could be as simple as going to the doctor for a knee replacement surgery, and you end up with a prescription to keep the pain away or at least get you through rehab, and the prescription is perhaps a little bit more than you need, or perhaps that prescription triggers something inside your body that causes an addiction, and after the prescription ends, your body and your brain don't necessarily want it to end. That type of thing can lead to an addiction, just a surgery, something that would be considered run-of-the-mill. On top of that, we also know that there are still people who experiment with other people's prescriptions. And we know that if a doctor prescribes it, and a doctor has had so much training, how could it possibly be harmful? How could this lead to addiction, right? This is a traditional way of thinking about a prescription drug. But we know that these types of prescriptions can be harmful. They can lead to addiction, to the point where one of the members of our task force on the governor's task force for opioid abuse is my ER doctor in Oconomowoc, Wisconsin. He ends up being a nationwide and renowned expert on this problem. He actually tells patients before and if he prescribes opioids, "I'm going to give you something akin to heroin." Can you imagine if you are a patient talking to my doctor, if he says something like that to you, how you might do a bit of a double take? And how you may caution yourself or even the prescriber and wonder how many pills are actually necessary, and how quickly
the power of the drug.
How quickly you can possibly get off of them.
There's nefarious issues that go on here too, even from the medical community. I think most doctors want to do it the right way. I really do believe that. And a lot of laws we've passed, or all the laws we've passed, we've worked in conjunction with the medical community, and they've been right there at the table willing to have these conversations. But I just want to talk. Cassie, my knowledge of Cassie's experience started with heroin that day of the overdose, but actually her genesis of it started with prescription drugs as well. And actually, in this case, it was not a legal prescription. It was actually diverted. We had actually had a doctor right across the river in Menominee, Michigan, was actually selling prescriptions of OxyContin in the mid-2000s. He ended up going to federal prison. By the way, he got the same 3 years Cassie did. Still gets me frustrated and angry when I think about that, because the lives that he took by being so irresponsible, and he got a 3-year sentence.
I want to talk about some of what's being done right now, the legislation that has already been passed and the legislation that at least some of which, or most of which, is likely to be passed. But I did want to just ask one simple question. Is this, you talked about how this cuts across lots of demographics. It seems though you hear a lot about younger folks, young adults, being the ones who are really at the crux of the problem we see today. Is that an accurate assessment, or is it way beyond that?
Not necessarily.
Okay.
You know how in television, you and I are always after a specific demographic, right? Because advertisers are always after a specific demographic. They're looking for usually young adult males, sometimes 22 to 54. The thing is, 22 to 54 is a gigantic age group, right? I mean, it's really tough to even identify similarities. It ends up that that's kind of what we're looking at here, but it's not limited to males. It's not limited to any ethnic descent. It's not limited to rural or urban or suburban. The target market here is impossible to find. And so that's why conversations like this are so essential. Everybody needs to talk about this.
So we met with Humana Insurance recently on this issue, but Humana is a large provider of Medicare and insurance, and they actually told me that nationally they have 10,000 senior citizens that are currently dealing with addiction to opioid medication. So to answer your question, if you look at this on a demographic breakdown, basically every single age group. We saw a death here in Milwaukee recently for a baby, I think just a couple years old. Almost basically every single age group has been touched.
And every social class too. We tell the story here, and it's not a happy story to tell, but Milwaukee County medical examiner who's had to, examine more than 300 people who have died of opioids related causes. His son also died. So it's a problem that does cut across a lot of different groups. So, Representative, after your daughter's experience, you began to get more involved, you began to learn more about this topic, and we've had a couple of rounds of legislation passed, the HOPE agenda, it's often called. What has the HOPE agenda, legislation that much of which you proposed, the governor signed off on, what has that done to address the problem?
Well, I mean, there have been two rounds up to this point, up until the governor's task force. The first round really dealt with what I call harm reduction. A lot of treatment experts will call it harm reduction, identifying the fact that we've got a segment of the population who's already addicted, so what can we do about it? Some of the changes were based around my own experiences and the experiences of my community. You know, Cassie asked me to get involved, but honestly I was still a little hesitant to do that, to put my family out there. But when I saw the obituaries of my friends and neighbors' kids on a daily basis, it was a call to action. So that was the extra kick in the pants I needed to do something. But those experiences, dealing with that day of that 911 call, as Cassie's mom was going in the door, her friends were running out because they didn't want to get in trouble once the authorities showed up. That happens all over the place. There's a statistic, or a kind of tongue-in-cheek statistic, that says 90% of all heroin users use with friends, yet 90% of all overdose victims are found alone. So we implemented a 911 Good Samaritan law in Wisconsin. We did it a little bit differently, and we're actually going back for round 2 of it in this session as well. And the reason what I did is based on what I knew myself and what I had heard from a lot of other parents, is we provided immunity for the person dialing 911 to save that life for simple possession. We did not provide immunity if you're a drug dealer, by the way, but we also did not provide immunity for the person overdosing. And that was a personal decision, like I said, based on what I knew and what I was experiencing from other parents. When you're desperate, you're afraid that your loved one we're going to give them immunity. They're going to go out and use tomorrow, and they're going to die tomorrow, not today. So we did not give that immunity. However, in this round, we're actually going back and making some tweaks to provide that immunity, but also provide some other safeguards. So we did that. We also made that drug, naloxone or Narcan, more readily available for first responders, police and fire, and that basic level EMTs, which is what, if they would have showed up in our case, Cassie would probably have been dead.
Explain what naloxone is.
Naloxone actually reverses the impacts of the overdose. When they administered it to Cassie, she basically came back to life within like 10 seconds, 15 seconds of them giving it to her. The first year of that law change, we saw 4,000 people administered Narcan or naloxone in Wisconsin. So some people will say, you know, is this really working? Well, there's 4,000 people that have an opportunity to get into long-term recovery today that they wouldn't have if we hadn't made that change.
So let's talk about where we are now, because clearly you, Representative, and you, Lieutenant Governor Kleefisch, feel more needs to be done. So the governor created this task force, and you've been talking to a lot of different people, but give people in this room a sense of who you were talking to in these conversations that led eventually to recommendations.
So you know, the conversation has not ended. The task force will continue to meet, despite the fact that John and I have offered our early recommendations based on a number of task force meetings that we did from fall through winter of this past year. We wanted to make sure that we stayed out ahead of this problem because we know that the bad guys will try everything in their power to stay out ahead of us and the law. And so what we did was we gathered a group of experts, everyone from the ER doc, about whom I was talking just a moment ago, to addiction experts, people who are in long-term recovery themselves, social workers, data analysts, as well as law enforcement. Even a pharmacist sat with us and managed to take the day in order to spend time hearing additional testimony. During the actual meetings of the task force, as you might imagine, we hear from a variety of experts in their fields, insurance experts, data analysts, people who work for counties that are doing different pilot programs. Our corrections secretary has a representative on the board. We know that this affects nearly every agency and department of government because we know that this affects nearly every person in the great state of Wisconsin.
Mm-hmm. So let's talk about some of the recommendations that came from this work, and there are actually quite a few of them, and we'll maybe highlight a number of them for the audience here today. Let me begin with the idea of treatment and diversion alternatives, increased funding for that. What are we talking about when we talk about treatment and alternatives, diversion?
Well, when you hear treatment, alternatives, and diversion, oftentimes you're talking about someone who is kind of in that crossroads of life. Are they headed to life behind bars? Our corrections department, which is still a corrections department and not a punishment department, we seek to help people because about 96-97% of those folks who come to us at a corrections department will be returned to the communities from which they came. So we seek to return them to their communities, healed, ready to go, ready to contribute to society. So there is a lot of treatment inside, but what if we can reach people before they head to our corrections department, this TAD program that we're talking about? What if we could instead divert them or get them to go through a drug court? Now, I've talked for a number of drug court graduation ceremonies, so to speak, and this involves usually a passionate judge and some parole officers or community officers who are willing to really come alongside folks who are struggling with sometimes self-medication problems, sometimes dual diagnosis, which has to do with both mental illness and their drug addiction, sometimes housing insecurity, sometimes job insecurity, sometimes a family situation. So usually there are multiple things at work in folks' lives, and we're kind of using something that is new to the government community called trauma-informed care in how we treat these individual cases. And the representative knows a lot about this because it's really important that we use trauma-informed care as we talk about this opioid and heroin crisis. It's basically where you talk to someone who has made a mistake, and instead of saying, "Why did you do that?" we say, "What happened to you that caused you to do that?" It's a very different way of speaking to someone, looking at the problem, but eventually you get to a solution probably with a little bit more knowledge than perhaps you would have had you approached it the traditional way. The treatment and diversions program goes at things a number of ways, but trauma-informed care, asking the right questions and finding people the right solutions before they're behind bars and getting the programming behind bars is usually not only better for the individual if they're just facing drug charges, but usually better for the taxpayer, because ultimately you're looking at not spending $30,000 to $40,000 a year in our corrections budget per person, but you're looking at getting someone treatment, but they're still able to perhaps go to work or get job training, maybe go to counseling or have interaction with their family members who may support them.
If I could expand on that a little bit. So I mentioned some of the challenges Cassie had seen that we knew about. One that we didn't came out when looking at trauma-informed care, trying to find out what were the underlying factors here. And what we learned was between the ages of 8 and 12, there was a sexual assault that was ongoing. And that's very common in people dealing with addiction issues. They're trying to cover up pains in their life. So just simply punishing the behavior isn't enough. Just simply providing 12-step treatment isn't enough. You need to look at if there is a root cause behind this. And just to talk about the growth of this program, when we began expanding in the first HOPE agenda, the treatment and diversion has been expanded 3-4 times during the whole HOPE agenda and now the task force. There were about a dozen plus counties or so that had treatment and diversion programs when we began this. There's now 46 counties and 2 tribes that have treatment and diversion programs, and there's still more need out there that counties that are stepping forward and saying we want to do it too. And from a taxpayer standpoint, the Lieutenant Governor mentioned this. So when I originally talked to my parole and probation officer in Marquette County, okay, you put 80 to 90 people in prison over the last 3 years, and how many of them have come back and how many of them are in long-term recovery? And they kind of looked at the floor and they had put about 90 people in prison. Most of them had come back on their sentence, and to that point, every single one of them had reoffended, had fallen off their course. So, and when we're paying $35,000 a year for a man and $41,000 a year for a woman in prison and getting 0 results, let's look at something that proves to be successful. Not 100%, it's more like 60%, but I'll take 60% success over 0% success at a much lower cost any day.
Another interesting idea in the recommendation, something that is called a recovery corps. Lieutenant Governor, I know you're enthusiastic about this idea. What exactly are we talking about here?
Actually, this idea was brought to us by one of the task force members, someone who is in recovery himself, a guy named Jesse Kramer, cool guy who gave us very out-of-the-box ideas because he talks to members of the addiction community every single day. It is not only his life, but his life's work. He said, based on kind of the AmeriCorps model, which I think most of us are familiar with, he said, you can use about $60,000, which is a modest investment for state government, Joint Finance Committee chairman over here, and you can train up about 20 members of a recovery corps. This is like a peer-to-peer specialist, someone who has been dealing with addiction, because we know that recovery for this type of addiction ends up being a lifelong process, and we can go into why that is and the brain science behind it in a minute, but it is a lifelong process, and if that is the case, sometimes we know that the very best folks to talk to are those folks with a shared experience. So not only the counseling training, but also someone who can say, I know what you're talking about because I've actually been there.
A couple interesting ideas that affect schools. Giving school nurses the ability to administer Narcan. That's a big deal, is it not?
Well, the School Board Association came to us with that request, actually. So we've made Narcan and naloxone more readily available. The main issue today isn't necessarily that it's not available, because it is, but there's liability. It's the litigious society we live in as we're sitting in the law school. And even it really shouldn't be a concern, because this drug, if they make a mistake and give somebody who may have some other type of health event Narcan by mistake, it does not harm them at all. Yet we still are in a society where liability is a concern, so we're going to provide immunity for the school if they administer the naloxone. Actually, one of my Democrat colleagues, because this is not a partisan issue, everything we passed so far has been unanimous, which is in of itself unusual, actually came with an amendment. They want to do the same thing through our UW system, and maybe even private colleges. We could look at that as well.
Speaking of the UW, there's another proposal in there. You would have the UW authorize a charter school, but it'd be a recovery charter school.
Right. So when you go, first of all, you spend first of all, you as either a private citizen paying with your own private dollars, or maybe your insurance, or the state through Medicaid programs, we spend a lot of our resources, putting people into treatment, helping them recover. Yet when you're a 16, 17-year-old, you're going to go through a 30-day program, a 60-day program, whatever it is. You're going to go back because you need to get your high school diploma, right? You need to get your education. You're going to go back to the exact same environment that you came from prior, with the same pressures, the same friends, the same everything's the same. And without the supports that you had when you were in treatment. So there's actually a national network of recovery schools. We already do have one in Wisconsin, but it's privately funded, and they've struggled with funding over the years. So what this charter school is actually a publicly funded school, just like it's a public Wisconsin K-12 system. So providing the per pupil funding, as well as access to Medicaid and or insurance dollars, if you have private insurance, to pay for the ongoing counseling, and you're being surrounded with people who have experiences, who have gone through treatment, as a way to support them in longer term recovery. The longer term that they are in recovery, the more likely they are to lead a lifelong life of sobriety.
Because it is a lifelong recovery. We know that treatment is a part, but recovery is a lifelong process. And so we've also advocated in the solutions report for recovery dorms inside our Department of Corrections, because we know that perhaps folks who start out with addiction don't also start out with huge criminogenic needs, but wind up with thefts or assaults on their records, perhaps because they were doing things as a result of their addiction. Use trauma-informed care to follow that path, and you realize that you might also need a place for a recovery dorm inside our corrections department.
I also want to make it clear that there is a law enforcement component to this. There is additional funding for more Department of Justice agents to help with the fight against the opioid epidemic?
Sure. We also want to make sure that there are resources allocated at our Department of Justice, because we want to crack down on the bad guys, the drug traffickers, the ones who are bringing heroin into Wisconsin, causing people to get addicted and causing another resource, a pipeline of illegal drugs that is fueling what has become a fire in Wisconsin. And so yes, our Department of Justice will have, we believe, 4 additional agents, and that was one of the recommendations that we have in our report, because it's absolutely important. We know that most people, we shared the statistic with you, don't necessarily start with heroin, but yet when John was dealing with Cassie's problem, he knew that heroin was a part of the problem. The reason this is so important, this enforcement piece is so important, is because heroin is killing people. Heroin is unregulated. It is brought up, we know, by Mexican and in some cases Chinese drug cartels, and it is killing people because people don't know what's in it. If people take a certain drug and are constantly chasing the high of that first experience, and they go onto the black market in order to try and achieve that high again, they have no idea what they are getting. It could be fentanyl, it could be carfentanil, it could be something that ends up ending their life.
Representative, we were talking upstairs, and there might be a couple of controversial recommendations, for lack of a better way of putting it, in this. A lot of the legislation that's been enacted up to date, as you pointed out, has been bipartisan, it's been unanimous. But there are a couple of things, and there's a commitment recommendation in here. Can you explain what that is and why that could be a controversial recommendation?
So I talked earlier about the immunity for the person overdosing, and kind of having the ability, even though it's not ideal, that most likely they're going to go into corrections. Well, we've been hearing from the addiction community, addiction treatment specialists, that there's still a reluctance on the people who are in active use to actually dial 911 to save that life, because the person, they do a buddy system. They said, if something happens to me, don't call, because I don't want to get in trouble. I don't want to go to prison. Believe it or not, they'd rather die than go to prison. That's how strong this addiction is. So they asked us, can we expand the immunity to the person overdosing? I said, well, I'm a little hesitant, because if we save them today, I have the fear they're going to die tomorrow. So what we looked at, we actually talked to our counties association, who works a lot with, at the ground level with addiction issues. And they talked about Chapter 51 statutes, which we already have for alcohol, which is an emergency detention where you as a family member or you and up to three people can go before a judge and actually ask the judge to temporarily commit you for up to 72 hours because you're potentially a harm to yourself or others. We already have that in statute for alcohol. We're actually mirroring that for drug use. And I don't expect in that 72 hours that the person is going to change their habits. They're still going to be an addict. But the hope is during that 72 hours, we can get them into a treatment program that can alter their life. So there are people that are against it. ACLUs of the world believe, and I don't want my civil liberties taken away either. But if I'm going to provide that immunity, I want that family to be able to have a tool that they can actually use to try and change the course that their loved one's on.
Lieutenant Governor, one other one that's gotten some attention is this recommendation that there be drug testing for people who receive welfare benefits, essentially. I'll use that term. Why does the governor, why do others feel in the task force feel that that's important?
Well, you have to understand that Wisconsin still has a largely goods-based economy. There are other states in this country that have moved largely to a service-based economy. And if you look at what we do for a living here, we do a lot of manufacturing, we do a lot of agriculture here. Those are both industries that we know will drug test for employability. So we've got to acknowledge the facts, the data on top of all of this. And then when you look at unemployment benefits, that is to be given to those who are employable, right? Those who are seeking work. But if you know that someone is not employable because they will test dirty, then why does the taxpayer then create the mechanism for unemployment benefits? We want to make sure people are employable. We want to make sure that people can partake in our resurrected economy, which we know is really needy right now with about 89,427 open jobs today. And if that is the case, then we want to get people on the path to recovery if they indeed need to be on a path to recovery. And that's why, as a part of this piece of legislation, we've attached the drug treatment too.
Would you need a waiver from the Trump administration? Would have to give you a waiver
you
to
got
do
it.
that?
But that's why we're pursuing a policy like that, because we need to get everyone who can into this recovered economy. We have a lot of employers today who are very needy. They need folks to come to work because they need to meet their customer needs. If we want to turn this to a labor market discussion, I will humbly ask anyone who is looking for work to take a look at our jobcenterofwisconsin.com website, because we really need people to take those open jobs. If people are looking right now at their nationwide assets or even their worldwide assets, how long are they going to keep a job open as an opening posted on our totally free website when they know they have an asset in Ohio or Louisiana or Mexico or China? How long will they keep that job open in Wisconsin before they decide that they're going to instead move that opening elsewhere? We want to keep our Wisconsin jobs in Wisconsin.
I'm supportive of this effort, and I'm going to talk a little bit more about it. But just to be clear, that this is actually not part of the task force recommendation.
No,
it's running parallel to this. Yet, like I said, I am supportive, and the reason being, I have opportunity to speak to a lot of people in addiction. I had and this is anecdotal, I'll admit that, but I was in Sheboygan County last year about this very same time. I think it's Pathways treatment near Kiel. Had an opportunity to talk to addicts that were going through recovery. There were about a dozen of them in the room, and I asked about this very same issue about drug testing, and I got a different answer than I anticipated. I expected people would be against it. They actually said they're in favor because it's a way to hold them accountable. Now, if you're talking about people that are in active use, they probably don't want to be held accountable. But we're doing all these things to try and help them become accountable citizens. And here are the people that are in treatment, that are in the beginning stages of recovery, want to be held accountable. So I think that's a great message. This isn't about being punitive. This is about finding people that might have a challenge with addiction and providing treatment and a pathway to employability. That's the best way for them to have long-term recovery.
Lieutenant Governor, one of the newspapers stories I read a couple of weeks after, or maybe a few days after the recommendations came out, there were a few folks quoted in it as saying, you know, we need to go bigger even, that this is just sort of nibbling around the edges. We have to do more. The problem is so big that this just doesn't do enough. What do you say to those people who raise those concerns?
In every policy solution, you have to weigh people's civil liberties and public safety with your hopes for the community. And obviously, we hope for the community no more addiction. And that has a lot more to do with prevention, I suppose, than it does even treatment and recovery, which is what we largely focus on in our solutions report, and what we've largely focused on today. What the Attorney General has done in prevention has been absolutely terrific. And when you ask about a focus, or at least a seeming focus on youth, I think there is a big prevention focus on youth because we have a captive audience in our K-12 schools, right? We actually can reach young people there. My daughters came home from their middle school the other day, and I got an email midday from one of their teachers remarking on the behaviors of the classroom and complimenting moms and dads, saying, I was so impressed by your children's reaction to the speakers today at the assembly. And I was wondering, my gosh, what was the assembly about? I couldn't wait for the kids to get home that night. They told me there were 3 addicts that came in and spoke. And half the kids, middle school kids, were moved to tears by these first-person stories. It is very impactful, and we know that we need to do more. And that's why we need you to talk to your friends and your family and your neighbors and the people behind you at church and behind you in the grocery store about this, because it has no geographic or demographic boundaries. We know we've made good progress. The epidemic, this is our prescription drug monitoring system that we've implemented. It's basically a way for prescribers and for pharmacists to kind of keep track of those folks who are getting prescriptions. So we know if someone is pill shopping, it's called, searching around for someone to prescribe more if they have an addiction issue. Even people who are crossing state lines to do these types of behaviors. We also know that we've got new stakeholder groups coming in every day that we're becoming aware of. We were at a task force meeting, I think it was in La Crosse, and there was someone testifying who had put up a big Venn diagram, you know, one of those overlapping circle diagrams with a whole bunch of stakeholder groups. And I elbowed Nygren, and I'm like, hey, why are realtors up there? What's up with realtors?
Yeah.
Why are realtors on the Venn diagram of stakeholders? And John whispers back, oh yeah, don't you know that people are now going to open houses and they are opening medicine cabinets and drawers in order to see if they can uncover another pipeline to feed their addiction or to sell. We have new stakeholder groups that we are uncovering every day. But we know there has been progress. With that epidemic that we have implemented, and we really put it into superdrive last month, we have now seen fewer prescriptions issued, about 15% drop year to year. Now, that's not about pain management, guys, as much as it is about prescribers doing very smart and kind of reformed behaviors based on current data analysis. This is really important because one of the gentlemen who came to testify for us was a doctor who originally was from India. And we asked him, so is this a big problem in India, this chronic pain problem and the prescribing? He said, no, we don't have chronic pain in India. What? And he said, no, it's not a thing. People pray, or people do various exercises, or they have different types of treatment, but we don't have like a thing called chronic pain. And so it's very interesting to me that you have a doctor to come in and describe that situation in the context of what we know, which is that though the United States of America has 4.6% of the world's population, we prescribe 80% of the world's opioids. Having fewer opioids available in those open houses or just in those medicine cabinets is actually a good thing, because if you have a good doctor-patient relationship, then you're not going to have any problem going back to your doctor and describing your symptoms and working out a good solution, whether that is a prescription or an additional prescription, or whether it's a different type of treatment. What matters here is that those prescriptions don't get into the wrong hands, and that if you ever are prescribed something like this, you don't end up with an addiction that you never imagined having.
Two final questions, then we'll take some audience questions. Representative, this is something that you mentioned that you hear from time to time, and I'll have you address it. And it's a sensitive question, and the question essentially is this. When people in the city of Milwaukee were dying from heroin, was there the same call to arms, the all decks on hand response? Or was it when it was white people who started dying in rural areas? When that started happening, then we got involved. What do you say to people who make that argument?
It was, I think, cocaine or whatever the drugs
crack,
of the
yeah.
crack of the past. Well, we're a representative government. I'm from Northeast Wisconsin. Milwaukee is not my world. I don't know I don't have a firsthand experience of the issues that face Milwaukee. I mean, I read about them in the paper. But I would say we as legislators only know what we know. And I was able to use my experiences to make significant changes. And by the way, people that are critical, we're not going to take a victory lap here, but most states are looking to us to copy what we're doing, not the other way around. We have more treatment available. We have more tools available for law enforcement, more tools available for the treatment providers. We're heading in the right direction, but we're not done. But for people that might say, why weren't you doing something then? I would challenge them. Leadership needs to come from your local community like it's coming from mine, because I saw what was happening to my friends and neighbors. That's where that leadership is most successful, to come from local leaders.
To wrap this up, 30 seconds from each of you on what people in this room can do to make a difference. You touched on this a bit, Lieutenant Governor, but wonder if you have any advice for what can make a difference.
How many of you have been, first of all, how many people don't know what opioid is? What types of prescriptions opioids are? Vicodin, hydrocodone, OxyContin, everybody knows what they are? How many have been prescribed one in the last 5 years?
Wow.
How about the last year? Just think about this from this perspective. Maybe genetically you're not predisposed to an addiction. But did you know that before you took that pill? Have the conversation with the doctor. While we're in a better place than we were, my staff jokes with me about being the face of heroin or opioids in Wisconsin. It's not always something when you run for office you want to be, but I'm fine doing it now. But probably this is, even though I'm in charge of finances for the state, this is probably the most significant issue I work on. Yet when I had knee surgery in June, the doctor who I had a conversation about all these changes that I was working on had ACL surgery. I was out of it. They gave a prescription to my wife. She went home, she filled it, she brought it home, I'm on the couch, tossed it to me, and it's 120 Vicodin. I took 10 over 3 days. Ask those questions. That's the best thing that you can do for yourself, for your family, and your community. Is this necessary? Is it appropriate?
Not everybody is going to have Dr. Westlake at the Oconomowoc ER who says, I'm about to prescribe you something akin to heroin. Not everyone will have that type of warning. A vast majority of the people in this room raised their hands when they said that they had an opioid prescription. I imagine, now I was probably pretty out of it too, but I imagine when I was in the hospital for my colon cancer surgery that that's what they gave me too. And yeah, today I'm not a part of the addiction side of the story, but I am in this way. My kids, that same middle school that had the 3 folks in recovery come speak to our children, does random drug testing if you want to be in an activity for middle school students. This is why we need to have this conversation with young people and with old people and with everyone in between. I can't stress enough, and now I feel like I'm momming on you, but I can't stress enough how important this conversation is to have. And then if you have these drugs in your house, just get rid of them, because there are lots of safe places. You know, when my father died of pancreatic cancer, and we know end-stage disease, there is a lot of palliative care. You maybe have a relative who has had palliative care, and you wind up with maybe a half dozen pills here and half dozen in that bottle. What do you do with that? Well, you know, perhaps 15 years ago, there weren't easy ways to find the solution. Today, there are. You could either go to one of those big drug give-back programs, or you can go to your Walgreens. We know that there are big drop-off points set up there, and not only that, your police department will take them too. 2 days ago, I had a huge restaurant chain that you would know come to me and say, hey, listen, we want to put one of those drug take-back machines, so you know those big like mailbox-looking things? We want to put them at our restaurants. I'm like, well, that's an interesting way of drawing more customers in. All right. But you have community partners who are willing to provide a very safe and non-judgmental, no stigma-attached receptacle for you to just toss the medication in. Whether it was yours, whether it was your parents, whether it was your kids, just don't even have them in your home. Because even if you trust everybody in your home, you'd be surprised. The most trustworthy people sometimes have something genetically in them that makes them a little bit more predisposed to a certain type of addiction. And you also don't know whether maybe those folks have friends who have that same genetic predisposition somewhere inside. It's an important conversation to have, and it's important to get rid of whatever extras you have lying around.
If I could add one more thing, Mike. The other thing, don't judge. Don't judge. Because, like I said, this starts off innocently in most cases. People hear the heroin, they automatically judge. You think of it, the 65-year-old grandmother that's addicted just accidentally that Humana was telling me about. Do you have that same level of judgment? That pathway could still happen. So just realize this really can happen to anyone, and it's oftentimes very innocent at its onset.
Because remember, the majority of us had our hands in the air.
That's very true. Let's take some questions. If you're in the seating bowl down here, press on the rim, not on the ball, but on the rim. Keep your finger down on the rim, and we'll be able to hear your question. If you're in the back and you have a question, please raise your hand. Ryan is in a blue shirt. He's got a microphone. He'll hold it for you. All I ask is that no speeches, just questions, and we'll get to as many of them as possible. We'll start back there. Go ahead, please.
Thank you for your comments. I really appreciate your addressing this issue. Question that I have is, when I look at the budget that's just come out, it doesn't appear to match what you're talking about in terms of TAD programs and moving forward in our state. And if you look at Minnesota, they have half the cost of incarceration as we do. I'm wondering if you could address, are we just in the inception stages of this? Is there a plan to roll out to counties in a larger way to actually make this real?
Right, so a part of our recommendations in the report that John and I put out was to apply for a number of federal waivers and federal dollars. And so what you are seeing, perhaps, is just a reflection of what is allocated in our state agencies. I don't know what version of the budget you saw, but the treatment and diversions are very reflective of what we have in our report, but you have to also understand that we are anticipating a number of federal dollars to also flow in, as they have in the past.
And I think our investment in TAD has gone up 8 times. Times 8 over the last several years. As I said earlier, we're at 46 counties. We're at 16 just a few years ago. So, and we're continuing to put more resources into it as the demand comes in. Something I've learned in government: you can't. If the counties, if the programming isn't at the local level, you can't make it happen. There has to be buy-in locally for these programs to be successful. And then the other thing, just on corrections, I'm a proponent. There's things we can do on corrections. I think, especially from an addiction standpoint, provide treatment, provide education, GED. The governor's actually putting more resources in to provide some staffing to get earned release, not early release. There's a difference. Earned release is, rather than early release is a bureaucrat making a decision that this person's going to get. Earned release is saying if you get your GED, if you get job training, if you get treatment in prison, you're going to potentially lessen your sentence or get out a little earlier. And that actually, I think, feeds really well into the governor's proposals on welfare reform. Getting everybody to an employable state is going to be helpful for everybody in addiction.
And one of the other things, we didn't get to every suggestion that was in the report.
There were a lot of them. Yeah.
There were a lot of them.
Yeah.
But just to help you understand how vast this group of suggestions and solution proposals is, I mean, we have medically assisted treatment programs. Additionally, I think 3 that we recommended in underserved areas in this report. A hotline for those folks who are dealing with their addiction issues that would be statewide. An additional hotline for physician to physician, because we know everyone is not an addiction expert, and we want to make sure that those folks who may not have that training have access to an expert who can advise them at a moment's notice. And we have a number of solutions on top of those things that we know will extend well beyond some of the more populated areas and reach even our rural areas. There are 2 additional fellowships in here. We want to make sure that our rural medicine is keeping up with the rural need.
Mm-hmm. There's online access to more information if you need it. Just Google Hope Agenda, and I know we've got a link for the task force recommendations.
Yes.
The last time that I got a pain prescription filled, I could take as few pills as I wanted to take home. I didn't have to take the 120, so you can ask your pharmacist, well, can I take 10? You don't have to have them in your home. But did they get your daughter's heroin provider in that process? And is there anything that you can look back on and say, well, maybe this was a sign that we were going down a bad path for other parents to know? Honestly,
I mean, there's been a lot of drug arrests in my area. I don't know if the specific dealer was arrested or not. Honestly, I was focused on my daughter's recovery. I mean, I think there's definitely a position.
You got that Michigan doc.
Yeah, they got the Michigan doc. I think there's a place for law enforcement definitely going after the people that are doing this for a profit. There's a big. There's
known who was giving it to her to help get it away from everybody else.
Honestly, like I said, this community is, first of all, they don't snitch on each other because there's pressures here, and you're dealing with unsavory characters, almost like mafia. Maybe it is organized crime. I'm not sure, but to answer your question, no, I don't. Off the top of my head, no. And was there something I should have identified sooner? Boy, you just identified every parent's guilt who deals with somebody with an addiction. Honestly, addiction was not in my world. Heroin was not even fathomable to me. Should have been, perhaps.
How's your daughter today?
I always struggle with that one, Mike, because she's doing good today. But one of the things that I guess is hardest for somebody who has a loved one with an addiction is they're good today, they're in recovery today, but they're never recovered. Recovery is something they will struggle with the rest of their life. So far, so good, but
She has a new baby.
she has a beautiful little boy, Henry, my first grandson, my first grandchild. So there's a lot of positive things, but there's every dad's fear still exists. So
I'm going to take another one. Yes, Chip, go ahead.
So in fairness, I have to announce that I'm the chairman of the Wisconsin Medical Society's Task Force on Opioids, and familiar with both of the speakers and a huge admirer of John for his personal strength as well as his legislative strength. One of the major sources of deaths in Milwaukee County and in our state is actually prescription opioids, and not heroin and not fentanyl. While the latter are actually making really big strides, and we're going to have to work on that, the reason that the Mexican cartels find us so profitable is because we are providing them with a population ready to be addicted because they're taking prescription opioids. And so getting those opioids off of the street is a major part of what we need to do. 7 out of 10 children who become addicted to opioids became addicted from friend or family members' prescription and not from their own. So, as you mentioned, Lieutenant Governor, Walgreens now has that available in 5 stores. Why 5 stores? Because they're piloting their concern about immunity and about the safety of the situation. My question is, what can a future hope of legislation do to help encourage that the activities that when this restaurant chain actually goes to their corporate office, they're going to say, as many of the lawyers in this room would say, at our restaurants, wait a second, no, I'm not so sure about that.
Yeah.
So what can we do about, what can Hope do about immunity?
Well, I think we can take a look at that. I mean, so Rebecca asked me this question just before we came in here.
We were on our way back from the bathroom, and I said, so John, 2 nights ago, someone posed this, but this is how solutions happen, right? Bizarrely enough, the folks who own a whole bunch of these well-known restaurants approached me and said, hey, what do you think if we did this? They're deeply concerned, right? And they know that they're probably doing a solid to the community. At the same time, they're probably doing something that may save a potential employee's life or a patron's life.
So the security is real, and think about it. I mean, the Walgreens, 24 hours a day. I mean, so the potential of robberies. We actually led the nation a couple of years in a row in pharmacy robberies. So I mean, these are real issues. I don't have a great answer for it. I mean, anybody, if you have watched the movie, or maybe your kids or your grandkids, Shrek, I've used this statement before. This is like an onion. The more you peel it, the more layers are there, and we're making progress layer by layer as issues come up. There's still some missing pieces, I think, that are glaring. Housing is the next task force. We're going to be talking a lot about housing, because if you don't have stable housing, that's one of those triggers, that just pressures that you have that makes active use more real.
One final quick question. Yes, sir.
Do you foresee a change in drug treatment possibly for people under supervision in state corrections rather than being revoked, being placed into drug treatment courts?
Well, I think the more prevalence we have of drug treatment courts, the better off the state is going to end up being. I've been a proponent of problem-solving courts from the very beginning, because you're diverting people from your corrections department and you're allowing them to continue with the support of the people who love them on the outside and work on improving their own life situation through their own efforts, their own hard work, and their own dedication, usually with the guidance of a PO. On top of that, they have to drug test constantly. And so we know that these are working for the lives that have been touched by them. That's why more dedication, more dollars for drug courts in this budget.
So I'm not 100% familiar with sure of your question, and maybe we can talk afterwards, but 2 sessions ago I did pass what's called swift and certain, where rather than immediately revoking, so once you're in the swift and certain program, rather than immediately revoking you for maybe a simple rule violation, you know what your parameters are, and maybe you get a couple days in jail rather than immediately sending you back to prison. We're looking for ideas like that we're looking for success. We're looking for better statistics in corrections that are actually going to change the trajectory so that we're not Minnesota. And by the way, Minnesota, one of the reasons Minnesota has lower numbers in corrections is they detain more of their people at the county level than at the state level. We're more of a state-based correction system, but we don't want to hear that. We want to hear in the future, we want to hear that we're actually, the goal is long-term, productive, tax-paying citizens. Just think about that. Rather than having people that are in our correction system, let's turn them into tax-paying citizens and helping us drive our economy. That everybody wins if we do that.
I'm going to wrap things up. Before we go, a couple of small pieces of business. Our next 2 events, unfortunately, if you haven't registered yet, they're sold out. We'll have Tom Nichols, the author, Naval War College professor, who will be in town on Tuesday to talk about his new book, The Death of Expertise. And then on March 8th, we have Milwaukee Public School Superintendent Dr. Darian Driver here. The reason why I mention that is that even if you can't be here in person, you can watch them on live. We stream our events live. We just finished streaming this one. You can also go back and look at them at a later time on our website, law.marquette.edu. Having said that, again, thank you so much for your interest, for your attention, and most of all, thanks to our guests, Lieutenant Governor Rebecca Kleefisch and Representative John Nygren.
Thanks for having me.